All right, good morning. Hope you all had a chance to dry off and get some coffee. My name is Lauren Reese, and on behalf of my colleagues in the Maternal Health Initiative, it's my pleasure to welcome you to the Wilson Center this morning. I see some familiar faces in the room, but for those of you who haven't been to the Wilson Center, a quick word about where you're sitting. The Wilson Center is celebrating its 50th anniversary this year as a living memorial to President Wilson. Recognizing his connection to both policy and scholarship, we bridge the worlds of academia, practice, and policy. The Maternal Health Initiative works across these communities to link maternal, reproductive, and child health care to international development and foreign policy priorities. Today's event, aligning the stars for quality reproductive, maternal, newborn, and child health care, it's a mouthful. RMNCH is much easier somehow. Marks the third and final event in a series we've partnered on with USAID's flagship maternal and child survival program. Previous events focused on strengthening health systems and scaling up successful reproductive and maternal health interventions. If you missed those events or want to revisit them, you can do so through our blog, newsecuritybeat.org. For today's panel, we have an incredible lineup of speakers, some who have traveled the globe to be here with us. I'd like to give a special welcome and thank you to our panelists and moderators, and recognize Charlene Reynolds, Holly O'Hara, and Kathleen Hill from MCSP for their support in pulling together today's event. A quick note about how the event will flow today. We have two sections, two different panels. There will be a quick transition between the panels, and I ask for you to remain in your seats so that we can do it as quickly as possible so that we don't take away from the discussion. Each section of the event will have its own Q&A, so please have your questions ready. We'll have colleagues in the audience with microphones, and we ask that you give your name and affiliation before getting quickly to your question. For those of you in the overflow space, I don't know that we have one just yet, but I imagine by 15 minutes after the hour we will. Please write your questions on the paper provided and hand them to the designated staff in the room. To kick off the panels, I'd like to introduce Chantel Allen, who will moderate the first panel. Chantel is a senior technical advisor with MCSP and has more than 15 years of field experience in leading and managing diverse health programs in developing and conflict-affected countries in Africa and Asia. Chantel, I turn it over to you.
Thank you, Lauren. Good morning, everybody. I don't know where all of you are from, but where I'm from, rain is actually very auspicious and a sign of good luck. So I feel very happy that it's raining this morning. So without further ado, to get started this morning, we're going to ask Barbara Hughes to come up and open our seminar and give her opening remarks. Barbara Hughes is the Director of Maternal, Child Health and Nutrition Office and USAID's Bureau for Global Health. Thank you, Barbara.
Good morning, and thank you for having me here. I feel like I know 50% of the people in the audience. We've worked together at one point or another over the last years, including people on the panel who I've worked with in a variety of countries. So what I thought I would do with my remarks is just set the stage. I will give you the heads up that I'm not going to say anything that you don't already know and believe in, but let's just frame where we are. So I would like to thank the Woodrow Wilson Center and MCSP for bringing all of us together today as we discuss what it takes and to improve and sustain high-quality reproductive, maternal, newborn, and child health care at scale. The at scale part is important. At USAID, we believe that nations have the opportunity to develop and prosper when people are healthy. Access to quality health services should not be a barrier in whether or not a woman survives childbirth or a child makes it to their 5th birthday. Healthcare systems must be accessible to all, especially the most vulnerable and underserved populations, in a way that meets their needs. USAID's investment in health focus on shifting the trajectory of a country's efforts so that our presence has contributed to helping to change their path. Within the health sector, USAID aims to build capacity and reduce disease burden while strengthening health systems to the point where countries are able to plan, fund, and manage their own continued progress toward resilient health systems. By partnering with countries on their journey to self-reliance, this is the new USAID buzzword. If you don't know it, you should. It's an important buzzword, and it's one I know that everybody agrees with. We're starting to talk about it more specifically in this age. By partnering with countries on their journey to self-reliance, our investments pay dividends now and in the future as we are working ourselves out of a business. I encourage you to learn more about how we partner with countries on their journey to self-reliance, and one excellent reference for that is our 2018 Acting on the Call report, which I don't know if we have copies of here, but it is available online. Improving quality is imperative to building strong, resilient health systems in that quality services are more effective and more sustainable. If we are addressing or discussing quality care for all, we have to ensure that services are safe, effective, timely, respectful, coordinated, and equitable, among other things. It's doing the right thing at the right time and place for every person every time. Quality improvement approaches must be responsive to families' health needs and aligned with country priorities, structures, and local assets. For all those reasons, sustaining gains in quality improvement is truly everyone's business. Countries are making and sustaining gains in quality of care through many efforts, including strengthened leadership and health worker skills, better measurement and use of health data, and greater community engagement. We are seeing national governments commit and recommit to quality improvement. We work with national governments to update their national RMNCH guidelines based on global evidence and equip their frontline health workers, including health managers, providers, and community health workers, with the tools and resources needed to not only institutionalize quality improvement methods, but ensure the provision of consistently high quality care to improve patient outcomes. USAID has long supported countries to improve their quality of reproductive, maternal, newborn, and child health care as an important part of preventing child and maternal deaths. We're pleased that the World Health Organization has initiated a quality of care network to harmonize and standardize multiple efforts to improve the quality of health care. We've been engaged in the development and implementation of the network activities from the very beginning at both the global and country level. I'm very excited for today's discussion, where we will hear from countries sharing their own learning and experiences improving quality in healthcare and of their ongoing commitment to continuous improvement. And I hope they'll also share with us some of the challenges they're facing and how they are thinking about those challenges. Quality improvement requires measurable, clear aims focused on health outcomes and what matters to clients. We know that protecting women and children from basic illness and ensuring access to primary health services is the first step to building strong families, stable communities, and productive nations. By helping countries meet the needs of their women and children, USAID support is yielding immediate returns now in the form of improved health services and health outcomes, and lasting returns in the future. Thank you.
Thank you, Barbara. I'm sure you will agree with me that this has definitely been the year for a spotlight on quality. In the last couple of months alone, we've had reports and significant, powerful recommendations of how to take our work forward in this global context. So we'd now like to ask Kathleen to help us frame our work and the seminar within this global context. Dr. Kathleen is the maternal health team lead at USAID's flagship maternal and child survival program. In addition, Kathleen provides leadership to the quality efforts at MCSP, and today's event and the MCSP work that we will highlight are a true testament to Kathleen's leadership, her wisdom, her many years of experience, and her personal passion for ensuring that we achieve quality for all. Kathleen, thank you for your thought leadership. Over to you.
Thank you very much, Chantal. Good morning and a warm welcome to all of you. It's my pleasure to offer framing remarks for today's seminar on quality of RMNCH care. I think I'll just use the abbreviation if you don't mind, because we want to be very inclusive, but stay within time. On behalf of the USAID Maternal Child Survival Program, I would like to thank the Wilson Center for co-hosting this event. The Wilson Center has been a wonderful partner to us, and we're very happy to have this collaboration. We are really happy to have the opportunity to have this conversation today, and I think and hope that at the end of this seminar you will agree with me that we have some very, very deep thinking and experienced panelists who will provoke us to think in all kinds of ways. The good news is that we are making progress in reducing maternal, newborn, child, and health mortality. And I always like to start with the good news because I tend to be a glasses half full person, but we know that we still have a very long way to go. During the MDG era, global trends in maternal, neonatal, and child mortality decreased, with less relative decrease for neonatal than for maternal and under 5, which I think is clear here. However, we know that many countries did not meet their MDG 4 and 5 MNCH targets, and we also know that global and national trends blur huge inequities within and across countries. And of course, this is true in high, middle, and low resource settings. In the US now, we have a huge focus on closing the disparities in care as part of quality efforts. Despite progress, major deficits in quality of care persist. We know that it will be harder to close these quality deficits in the SDG era. We have plucked off many of the lower hanging fruit in the MDG era, and we do face a harder road to go. The Lancet Global Health Commission for High Quality Health Systems, published just under 2 weeks ago, calculated the excess mortality in low and middle income countries due to poor quality of care versus non-utilization of care, and demonstrated that over half of deaths amenable to care, as opposed to population health, are due to poor quality. And we're really fortunate to have Margaret Crook, the lead commissioner, with us. And I thank you, Margaret, for your leadership in doing this quantification, because it's a huge advocacy tool for this revolution that you're calling for. Countries in the global health community are rightly focused on universal health care in the SDG era. However, as quoted here in one of the global quality reports that we'll discuss, UHC will remain an empty vessel if quality is not front and center, in addition to universal access and protection from financial hardship. Every technical area in global health, and I've worked across many, has its specific quality of care complexities, challenges, and opportunities. For reproductive, maternal, newborn, and child health, quality care must be integrated across the pre-pregnancy, pregnancy, childbirth, postnatal, infancy, and childhood continuum of care. Quality care must reliably deliver integrated packages of evidence-based interventions and services, including immunization services, for every woman and child along each phase of the care continuum and across care platforms and system levels, including for women and newborns and children who develop complications and require more advanced care. And this is no small challenge for all of us. At each phase of this continuum, key domains of quality, which are noted here, which were defined nearly 20 years ago, I would say at the launch of the quality movement here in the US, each phase must meet these different dimensions of care that include quality, effectiveness, safety, equity, people-centeredness, and more. However, evidence demonstrates widespread gaps in each of these domains across maternal, newborn, child health, and all healthcare areas, actually. Often, care is not only ineffective, it fails to meet evidence-based guidelines, but it is unsafe. For example, the overuse of obstetric interventions such as uterotonics to speed labor in many settings. And in too many cases, we know that care is not only disrespectful, but actually abusive. And there's lots of evidence on this that many of you are probably familiar with. In 1966, Donna Badian published a framework for conceptualizing and measuring quality of healthcare that continues to be very useful for us today, and that is reflected in many of the global reports that we'll discuss in a minute. In his framework, it is the combination of inputs and care processes that yield outcomes. Multiple studies have demonstrated that availability of inputs alone, while essential, will not correlate with higher quality care or better health outcomes. And historically, we know that many efforts in global health have focused on key systems inputs for provision of quality care, and often have done so in silos. We know governments have to support a system in which care is integrated, but we also know that many of development partners and donors often support individual pieces of these essential inputs. In the last 3 months, 3 global health quality reports have been published that all emphasize the importance of focusing on processes, on the interaction of essential system functions and outcomes, health and person-centered, in addition to inputs. And all 3 reports highlight the huge personal and economic burden of poor quality and low resource settings, and the importance of placing quality at the center of universal health care, and the importance of leadership, governance, accountability, and systems thinking and system-wide action for improving quality. It's not just about quality improvement at the service delivery level. We know that. The People's, in conjunction with the Lancet Commission, a civil society report, and we do have many of the authors and contributors in this room, was published. And I encourage you all to look at this. And, excuse me, I'm sorry. We see here a quote from a woman from a low and middle income country, and we might hear this also in a high resource setting. And basically, we cannot know what was hard for her if we do not listen to her. We have to listen to people, and we have to engage community and civil society as part of our ongoing efforts to design and improve care. The WHO multi-country network for improving MNCH was launched in Malawi in 9 first-phase countries last I think it was February of 2017. We were saying yesterday it's still really a baby. And we are very honored to have Blerta Maliki, who leads this effort on the part of WHO, and you will hear more about this work in panel 2. I would like to just say that a great strength of this framework and the approach of the network is that it prioritizes provision of competent care and experience of care and activated health system functions. And it's really been an honor for MCSP to be able to work with the network. One of the key messages from all 3 global reports, from the one of the organizing principles of the network, as well as our own experience, and I think many countries' experience, is that we must work across system levels at national, subnational, and service delivery level, and that we must lever existing systems. And that context really matters. A brief word about measurement, and then I'm almost done with my opening comments. Many efforts are underway to identify meaningful quality of care measures that can be used by different actors across different system levels. And we know there is not a one-size-fits-all, and I would argue that in RMNCH, we've been a little bit perhaps behind where we would like to be with respect to identifying these quality of care measures. The WHO Quality of Care Network promotes a set of common quality measures for monitoring across all learning sites. And over half of these measures are focused on quality of care and outcomes. And MCSP, it's really been an honor to co-chair with WHO and UNICEF this monitoring working group. MCSP works at global and country level in 30+ countries. And we feel very fortunate to be able to engage at these multiple levels, to bring the global resources and learning to the country, and to bring the country realities and learning at all levels of the system, including that midwife in a peripheral health center and the district manager. I'd like to end by saying that we know it takes a global and a local village if we want to provoke and support a true revolution for quality. And you will hear from a variety of perspectives, including government, WHO, development partners, and academia in the next 2 panels. Thank you.
Thank you, Kathleen. This morning I have the privilege of moderating this wonderful panel. And implementing quality improvement requires an interesting balance between having very clear aspirational goals and being rooted in local realities, local context, and local systems. And as Theodore Roosevelt said, you have to keep your eyes on the stars and you have to keep your feet on the ground. And you have to do it at the same time. So our first panel today is really going to help us explore what does it take? What does it mean to really, in the country level, to improve quality of care? And I'm happy to have my 4 inspiring panelists who will share examples from 3 countries, Uganda, Nigeria, and Madagascar. And my 4 panelists are Dr. Jessica Sabiti, who's the Commissioner of Maternal and Child Health with the Ministry of Health in Uganda, Dr. Chubugu Okoli, or Ugo, as we like to call her, who's the Deputy Chief of Party of USAID's Maternal and Child Survival Program in Nigeria, and Japaigo's Deputy Country Director. Then we have Dr. Boniface Onwe, who is the Director of the Public Health Department for the Ebony State Ministry of Health and the Ebony State Program Manager for the Saving 1 Million Lives Program for Results. And finally, we have Eliane Razafin. I love your surname so much. Razafamandimbi, who's the Chief of Party for the Maternal and Child Survival Program in Madagascar. As a side note, for those of you in our audience, you will have full bios of all of our panelists and speakers. And for those of you online, tomorrow the bios and all of the presentations will be available. So a very warm welcome to our panelists. You've all come from very far distances to be with us. And today our panel is going to follow the following format. We will do very short country presentations. I will ask some additional reflective questions based on the presentations. And finally, we will open it up for you to ask our panelists questions, because I'm sure you will have many. So without further delay, we'd like to ask Dr. Jessica Sibiti to take the podium and to share her experience from Uganda. This presentation is really going to take a systems view on what does it take to strengthen government systems, processes, and tools and structures to make sure that a country is investing for a commitment to quality in the long term. Thank you, Dr. Sibiti.
Thank you very much, and thank you for having us here for this important meeting. I'll begin by taking you through a bit of the history of the trends on the mortality figures in Uganda. And as you can see, to begin with, the current trajectory in Uganda shows that Uganda will not be able to meet the targets for the SDGs and also the national targets on mortality, since mortality has not improved over several decades. We are also aware that Uganda has one of the highest birth rates in the world, and that means Uganda will definitely lose more children and mothers in absolute numbers between now and then, due not only to inadequate implementation of the many maternal child health interventions, as you can see from the scorecard, but also due to poor uptake of these life-saving interventions. This is partly due to the distance and the cost issues, but also because of the early experiences and disrespectful treatment and lack of trust patients have in the healthcare system. In fact, there's been a big acknowledgement in the country that over the years, quality of care has become a lesser priority. There are people who think that in the 1990s, we actually focused more on quality of care than now, and that has been a key driver for the Uganda processes. I would now like to take you through some of the policy enabling issues we've been tackling to be able to set a conducive climate for moving into focusing on quality of care. So working closely with our partners and other actors in the country, in 2013, the government embarked on a process of institutionalizing a quality assurance and improvement system, which was guided by a development of 5-year health sector quality improvement framework and plan. And in addition to this overall overarching plan, we were able to develop a new RMNCH sharpened plan, which was later updated in 2016. And this plan prioritizes key areas for investment. And since then, we've been able to mobilize resources, not only to implement the whole plan, but also to focus on quality improvement. We've received a grant from the IDA and the GFF to support some of these interventions. Thinking about the additional lives we can save in terms of providing effective, safe, and respective care, Uganda has also gone ahead to adopt the new WHO standards and network initiative. Uganda is one of the first 9 Pathfinder countries, and we've been able to domesticate these standards. We've developed a roadmap for implementation, and we've also begun doing the initial capacity building activities. In fact, we are now implementing in 29 districts, and 5 of them have already gone through the whole cycle of inception, facility readiness assessment, capacity building, coaching exercises, and also sharing the results. Unfortunately, I'll not be able to share the results here, but in the future meetings, we'll be able to share some of the results. On creating policy environment further, we've also been able to define a governance structure and different packages for service delivery for the healthcare system, focusing on the continuum of care along the life cycle, but also making sure that we define service packages for the different levels of care, right from the bottom to the top, what can be delivered and what type of standards are actually expected. And this has not only provoked alignment of interventions, but also it does emphasize the system-wide approach we're trying to promote in the country. This slide shows the sharpened plan and the strategic shifts in the sharpened plan on the left side. And then on the right side, we show how we have been able to do the bottleneck analysis within this plan on the key quality of care gaps we want to deal with and the areas of focus. Being able to calculate and agree on the numbers of lives saved over the next 5 years using this plan has been able to amplify joint efforts and voices from different people around common goals, around common survival priorities, and also around common bottlenecks to tackle, including quality of care. The next slide shows our theory of change, which clearly communicates the message that efforts towards optimizing universal healthcare coverage should not only strengthen access, but crucially should ensure that services that women, adolescents, and newborn and children receive are actually effective, they are safe and respectful, and they also address their needs which they deserve. The next slide I'm going to share with you here is about learning. I want to make specific mention of learning because this is one of the newest element of our approach. And the approach here has been implemented through maximizing available interventions, but we have been able to identify a few tracer interventions for the beginning to use to track the issues and how we learn this process. We are also trying to expand on the platforms for sharing information. We've introduced an annual RMNCH assembly and a quality improvement conference for every financial year. And we are also trying to maximize the use of technology to be able to share data, real-time data on dashboards. I would like to close by sharing some of the achievements and maybe some of the lessons we have learned through this process. This growing public health experience on quality and ambitious targets set by government to save more lives has actually raised the bar for the government systems to produce better health outcomes and greater social value from our services. And in response, the government has established a service delivery unit at the highest level called, popularly known as Hakuna Mchezo. This literally means that there are no more games from now. It's a Swahili word. And this service delivery unit is actually housed in the Prime Minister's office. And this has actually put pressure on sectors and government agencies to be able to focus on quality of care. We have generally learned that poor quality infrastructure and healthcare practice can actually be improved through a nationally recognized quality of care standards, certification system, and accreditation measures can actually be set up, and you can begin a journey in this direction. We now know that, and I've started seeing that technical competencies and motivation of health workers, despite poor staffing, can actually be improved, and is able to determine and improve individual performance activities using these mechanisms. However, we have also learned that the most effective approaches are those that involve active participation of these health workers, including education outreaches that entails the use of a trained personnel coming from outside and working with the people at the facility level to ensure that they meet their healthcare professional requirements. And we have actually decided to incorporate in our assessment tools a component for providing technical assistance when we go to do assess. We have continued to, lastly, I would like to mention that we are continuing to learn, and learning is going to be a major component, especially at the management level. We don't only learn from what we say, but we learn from the data, and data has become a key driver for the process. And we are also hoping that in the next phase, we strengthen the community component and monitoring of services using welfare groups and community health workers in the process. Thank you very much for listening.
Thank you. Thank you, Dr. Jessica. So moving from the national focus, we're going to take a slightly different lens now. And we're going to focus on a country example from the state perspective. And we're going to ask Dr. Onwe and Dr. Okoli to come up and take the podium and share a really interesting example from Nigeria. Nigeria is a country that has prioritized maternal and newborn health and is also one of the first wave countries participating in WHO's Quality, Equity, Dignity Network. And we're very happy that we have a dynamic duo this morning to share an interesting example from a state Ministry of Health perspective and also from a project perspective. Thank you.
Thank you, Chantal. Greetings from the people of Nigeria. Our presentation is focusing on improving quality of maternal and newborn care in Ebonyi and Kogi states of Nigeria. As you can see from the chart on display, Nigeria was not able to meet the MDG goals 4 and 5, and still contributes to 14% of the global burden of maternal mortality and 10% of the global burden of newborn deaths, which is terrible. Then on the SDGs, the country is only on track for SDG 13, which is dealing with climate change. Nigeria conducts National Demographic and Health Survey, which happens every 4 to 5 years. And in the last one, conducted in 2013, there was a curious discovery. We discovered that the locations, regions of Nigeria that have high population of skilled birth attendants did not have the expected reduction in perinatal mortality compared to the ones that have low skilled birth attendants. The implication of this is that even the quality of care our skilled birth attendants are delivering is suboptimal. As such, MCSP decided to support the government of Nigeria to implement interventions aimed at improving the quality of care around the day of birth and especially in the neonatal period. Our goal is actually to ensure provision of right care for every woman, newborn, and child at the right time, every time. But Nigeria is a very big country. So to achieve this is not easy. There have to be involved engagement of the stakeholders at different levels. And this is what MCSP helped us to do. Starting at the national level, there were multi-level stakeholders engagement, and these stakeholders decided to look at the WHO Quality of Care Framework for Maternal and Newborn Health, which was eventually adopted by the country and approved as the guide for the implementation of quality of care in Nigeria. And because this will be implemented in 2 states, the governments of the 2 states, Ebonyi and Kogi states, were involved at all levels of the development of the National Quality of Care Strategy. These are the 2 states that benefited from the program, Ebonyi State and Kogi States. Now, to give us a guide on what to do, in 2016, there was an initial baseline assessment that was conducted actually in 2 phases. The first phase was a facility readiness assessment, and then followed by a more robust quality of care baseline assessment. The aim was to identify critical gaps that needs to be filled to improve the quality of care. The following gaps were identified. Limited skills, mainly in proper monitoring of labor using pathograph, newborn resuscitation skills, active management of 3rd stage of labor, infection prevention and control practices, and we also discovered that, we are not there with regards to respectful maternity care. Also, cutting across most of the facilities is limited availability of essential reproductive, maternal, and newborn health commodities. Having done that, 321 facilities were selected and supported for quality of care for the implementation of maternal and child survival program in the first place. I'll come to that later. Now, at the state level, a lot of things have to be done, because just as we involved, there were multi-layer stakeholders' involvement at the national level. There was also multi-layer stakeholders' involvement at the state level. So each of the states also, following the direction of the national, adopted the WHO Quality of Care Framework on maternal, newborn, and child health. And both states are selected as demonstration states for quality of care in Nigeria. What we also did is that with the support of MCSP, out of the 321 facilities being supported, we selected a subset of 91 facilities, 45 in Ebonyi State, and then 46 in Kogi State, for in-depth implementation of quality of care interventions centered on day-of-birth services. To achieve this, we have to have a coordinating mechanism, beginning with constituting a quality of care committee at the state level. And in each of those facilities we selected, we had to form quality improvement teams with very clear responsibilities. Each had their work plan. And then we also agreed on the indicators and the targets we aim to achieve at the different levels. We have similar indicators, but our targets at the primary healthcare, secondary, and tertiary are different. Next was to bridge other gaps identified. So health care workers' capacity was built on both clinical and QI skills with additional on-site supportive supervision. And we had periodic peer reviews to reflect on what is going on. We have a quality care dashboard so that the indicators being tracked are on the dashboard. And my colleague, Dr. Gokoli, will take the presentation from here to show us the results so far. Thank you very much.
Okay, thank you, Dr. Onwe. So the next couple of slides will focus on the results of the QI work that Dr. Onwe has just described in the 2 states in Nigeria. The health facilities and the state actually selected the indicators to measure progress. And these indicators were based on the findings and the gaps identified in the baseline, as Dr. Onwe has described. For this particular chart you're looking at, it's focused on the maternal health indicators. And we chose 3 of them: the active management of stage of labor using uterotonics, and you can see that in the dark blue line, the use of pathograph for monitoring labor, which is the lighter blue line below, and of course measuring BP and fetal heart rate on the day of birth, which is the red and yellow respectively. As you can see from the slide, there is a significant improvements made over time from 2016 when we started to June 2018. These improvements are for all the facilities. Of course, each facility, actually all the facilities improved at different rates. On the side of the chart, on the left side, you will also see illustrative changes, which is like the processes that underpin these improvements that we've seen. And I'll just mention one, which is people-centered care. By reorganizing care pathways, we actually benefited the patient, especially in terms of time that they spent in the facilities when they visited. The next chart is focusing on the newborn health care. We focused on the essential newborn indicators, and one of them was the care application of clohexidine to cord care to prevent newborn infections in the dark blue line. And another one was the initiation of breastfeeding within 30 minutes of birth in the red line. As you can see again, we've made significant improvement and also actually maintained that improvement in the last 1 year. On the side, you would also see illustrative changes. One of them include setting up newborn corners in the labor wards that had all the equipment and commodities. So for instance, we had like the bag and mask readily available when we find that a newborn is asphyxiated and needed resuscitation. We didn't stop at that. We also looked at outcomes as well. So if you look at the chart on the right side, which is the gray line, it's looking at the number of newborns who were asphyxiated, or percentage of newborns asphyxiated that were actually successfully resuscitated. An important measure was the obstetric case fatality rate. We actually adapted from the QED network in terms of their measurements and chose to actually look at this case fatality rate, which is made up of obstetric complications and deaths from those complications. And as you can see from the line when we started, the red arrow, that we are having a decreasing trend at the moment. So I would actually like to share a couple of reflections and recommendations for those that are embarking on this sort of activity. We know that partnership and leadership at all levels is essential. You know, you have to show leadership at the state, the local government, and the health facility to actually make a difference. We also know that if you build the skills of healthcare workers, that is just not enough. You have to also get them to practice, support them on site to ensure that they're actually practicing and you're correcting and they're actually seeing the support being given by the state. We know that the pre-service education is essential as well. And for pre-service education, there are two things. One is actually building the capacities of the tutors to ensure that they are producing healthcare workers that are thinking of quality from the start, and also equipping pre-service institutions as learning centers. Documentation of data, documentation is actually not very well used at the facility level. So two things: documenting care, very important, also documenting data for decision making, also important. And of course, lastly, the shared learning, which we have talked about. It strengthens critical thinking, ensures that we uptake best practices, and ensure that we also correct what we are doing as we go along. So I would like to end by thanking all the partners that have actually been involved in this work, from the state to professional associations. And I would like to say thank you also for listening to us this morning. Thank you very much.
Thank you, Dr. Onwe and Dr. Okoli. Eliane, so the final example of our country series this morning is going to focus on Madagascar. What does quality improvement look like in a country that's at the beginning of their quality journey without a national strategy and formal structures? So Eliane will share an example of work done in Madagascar at significant scale, covering 2/3 of the country and more than 800 facilities. Thank you, Eliane.
Thank you, Chantal. Good morning, everyone. It's really a pleasure for me to be here today to share the experience of Madagascar. Like many African countries, Madagascar did not achieve the MDGs for maternal and newborn health. In fact, over the past 20 years, although Madagascar made progress for reducing under 5 and infant mortality, over the same period, neonatal and maternal mortality have stagnated, as you can see as a red line on this graph. In response, in 2014, the government of Madagascar developed a roadmap for accelerating the achievement of the MDG related to maternal and newborn health. And the goal is to halve both maternal and newborn mortality by 2019. As you can see, the goals in dot line here. The USAID Maternal and Child Survival Program was given the mandate to support the Ministry of Health to achieve these ambitious targets. And in 2014, we started implementation with a detailed facility assessment to identify the challenge, to highlight priority for intervention, and the results showed significant gaps in the facility readiness to provide quality maternal and newborn health services. Some key gaps include few provider trains in BIMANG, issue of commodities, poor infection prevention and control, and poor infrastructure. So the overall goal of the program was to support implementation of key aspects of that roadmap in USAID priority region, with a focus on improving quality of maternal and newborn care. This was an ambitious project, I have to say, with a large geographic scope. We had to implement in phase over 3 years. We were able to achieve coverage of the 16 regions covered by USAID. And with that, we covered nearly 2/3 of the country, 800 facilities, and about 1,500 providers trained to offer service to a population of 17 million inhabitants. Coverage at scale of high-impact intervention through skilled provider was a major priority of the roadmap. However, in order to implement, to have impact and to have really quality of care, we needed to engage with the health system at different levels. At national level, we needed to update the key strategic document like the norms and protocol, the guidelines, to reflect the global guidelines. At district and regional level, we engaged and built the capacity of the district teams to undertake trainings and supervision, to monitor the facility performance, and really truly lead the efforts with objectives that they can sustain those efforts in the future. And of course, at facility level, the providers needed the training, the supervision and equipment, and they were also supported in monitoring a standard data dashboard for tracking key quality indicators. In selected facility, MCSP supported implementation of a QI, clinical governance team, and also engaged with the community to improve the quality of care in the facilities. The results I will share in the next slide are aggregated data from the MNCH facility dashboard I was mentioning. Over 3.5 years, a common set of 8 quality of care indicators were tracked monthly for about 600 facilities. One key process indicator was related to screening of preeclampsia, eclampsia. Indeed, early detection of this condition via systematic blood pressure screening is critical for reducing mortality. And this slide demonstrates increasing rate of blood pressure screening during antenatal visit from a baseline of 40% to above 90% of antenatal care visits within just a year. And we are able to sustain this at this level until the end of the program. Facility introduced changes in client flow to ensure systematic blood pressure measurement during antenatal visit. Another example of change introduced by facility is negotiating with pharmacy so that in the delivery room we have an emergency kit with oxytocin and magnesium sulfate just in case. Another process indicators that we monitored was around postpartum family planning that MCSP introduced at scale. Providers were trained in counseling, but also in the provision of services, including implants and IUD postpartum. Reorganizing the services and training providers facilitated the counseling both in antenatal care, in early labor, and also after delivery, resulting in really increased number of women taking a family planning method after delivery. Before, provider just refer the woman for family planning to another department or to another facility, with the risk that actually they come back after a few months to just deliver another baby. The dashboard not only allowed us to monitor process indicators, but also some key outcomes. As you can see from this slide, significant reduction were achieved in both maternal mortality and fresh stillbirth at the primary facility level for nearly 100,000 deliveries. These improved outcomes were not only seen at the facility level, at the primary facility level, but also at district and regional hospital. For the approximately 60 hospital MCSP supported, similar improvements were achieved as monitored through the data dashboard. And this slide show reduction in newborn mortality rate in the 5 regional hospitals where MCSP supported introduction and the monitoring of a QI team. Those QI team or clinical governance teams developed action plans to improve quality of care. And one example of change that was really tremendous was ensuring that newborn resuscitation kit was available in the operating room. So after a C-section, the midwife did not have to carry the baby to the neonatal unit, often which was located in another building, saving lives. To conclude, I would like to say that even in a weak system without quality improvement structure, it is possible to support district manager and facility provider to measure and improve quality of care at a relative scale. In addition, we demonstrated that introduction of QI team, a clinical governance team, helps strengthen the overall management and also the organization of healthcare services so that we can promote an enabling environment for quality of care. But of course, it is essential that we have leadership and commitment of manager and health workers across all the systems level. And in fact, despite the progress we had at the district and facility level, things have not moved very fast at the national level. And more advocacy is needed because to be able to sustain and continue improvement work, national level leadership is really essential. And the development of a national quality strategy and structure remains a high priority for Madagascar. To end my presentation, I would like to really acknowledge that this result I just shared was really represent the hard work of the trained providers, the district and regional MOH team that we supported, the MCSP team supported, and of course, funding from USAID. Thank you for your attention.
Thank you to our panelists. These 3 country examples are really rich, and it feels like 7 minutes is just not enough to get into the details. So I've been thinking, as I've been listening to them talking, I've got a question for each one of them just to dig into a little aspect before we open up to you as the audience. So I'd really like to start at the national level. Dr. Jessica, your example was very rich because it showed a very thoughtful, articulated approach to setting systems and processes in place from a government point of view. And I'm sure as you were preparing this presentation, it also took a lot of reflection from yourself and like, where are we? What are we learning? What's going well? What are my challenges? So I don't know if you could really start off by just giving us some of those reflections of where you are in the process and where you see Uganda moving forward.
Thank you very much. This morning, my presentation was mostly meant to reflect our journey so far. You're all aware that, as I said, quality of care is not a new thing. We've been doing quality of care for several years. Uganda is one of the countries which actually benefited from the Saving Mothers Giving Lives. And we've just finished our celebration with the Big Harvest meeting. And we're able to reduce mortality within 1 year of 30%, which actually for us was a very important, not only a proof of concept, but it inspired us. At this point of time, my presentation is reflecting on some of those experiences. And one of the greatest things we learn is that whereas it's possible to change quality of care, the greatest possibility of success comes from, of course, multifaceted interventions, building on health system, but it's very important to have a progressive policy environment. What is happening in some of the SMGO districts since the project ended, mortality has gone up. And we're now battling with these districts and telling them, we had proper entry processes, we came to the leadership, we planned with you, we converged all the efforts together, we did a system-wise approach, and we thought that had solved it. This time round, we want to see more ownership and leadership in this process. And when we talk about leadership, we want to learn from the data, the information we have. And we don't want only to teach technical managers. We want other managers. And when I talk about managers, I'm talking about politicians, because right now they're the ones writing the complaints. We are losing so many mothers from C-sections from this hospital because they were not used to the deaths that had gone down dramatically. I'm talking about training managers learning from but also using the data. So in our new process now, because now we are moving into another process and using other entry points to improve quality, like performance-based financing, we are expecting districts, first of all, to apply. They must show interest and make commitments. We're also expecting, we're assessing the facilities, and the facility must qualify. We have set some thresholds, and if they don't qualify, the district can talk to partners, can talk to USAID, can mobilize their own resources to make sure that these facilities actually enter the game. So we are kind of reflecting a bit and trying to make sure that creating a progressive policy environment is more important than running for the results. Because if you converge all these resources together, if you bring everybody, you should be able to get results. The question is, what happens when the resources go? That is one. The other thing also we are trying to do is to make sure that we have participation. We want to converge efforts from the academia, from the community. We are working on a very small initiative with the MCSP actually team here to expand the reaching every community, the RED strategy, to expand it to address RMNCH. And one of the things we are looking at, first of all, to get the denominators right. We're doing new catchment mappings. We are registering the households. We want to know where our target populations are in each community. How many adolescents? How many pregnant mothers should we expect? Even when you give incentives and results, the health facility must know I'm expecting 20 mothers, but I'm seeing 5 mothers. And then tag this into the planning process and do a bottom-up approach. So our new emphasis is to push for participation, as I said, and make sure that we lay a foundation for policy using a system-wide approach, so that even when the funds dwindle, we have a World Bank loan now. Once this World Bank comes to an end, we have a system which can progressively push these things forward. So that is our interest.
Thank you so much for those very thoughtful observations that are relevant, I'm sure, to many other countries that are starting to approach similar places. I want to turn my question now to Dr. Onwe. So moving from the national, that very strong, thoughtful national point of view, I was really struck in your presentation about the critical role that that subnational level plays, because you link national policy to implementation, but you also are able to feed back actual implementation experience into the national level and into policy. And your work that you've done really with implementing in Nigeria, but also in participating in the Quality, Equity, Dignity Network as one of the 9 countries. So if you had to give a recommendation to another manager, maybe from a different country, who is really working at that linking level, at that subnational level, do you have any high-level recommendations that you could provide?
Thank you very much, Chantal. Yes, there are. What I consider most useful in the first place is to have a harmonized strategic direction, especially if the state is lucky to be supported by multiple partners interested in quality of care. The partners have to first of all come together with the relevant authorities, agree on what they want to do, and then it will be best to have a policy document that clearly spells out what they want to do. All relevant stakeholders have to be involved at all periods, at all stages of the implementation. And then, very important, if indicators are to be tracked, which usually will be tracked, there has to be a consensus on reasonable, measurable indicators that can be tracked. And I will advise that at the start, don't track every indicator, because it will be difficult. These things take a lot of energy. Another thing is that if you are starting, it is good to know where you are. And because of that, I will strongly recommend that there is a baseline first, and that baseline will help to identify existing gaps. And then if those gaps are identified, then interventions can be designed to bridge those gaps, and that will be very, very helpful. From our own experience, what we have also discovered is that it may not be possible to roll out QI activities across all facilities at the same time. So I will recommend phased implementation, which means start with a small number of facilities, then stabilize those facilities, and then move on to scale up to another facilities. That's why in Ebonyi State, MCSP is supporting 119 facilities. We are tracking QI indices in 45, and we are hoping to scale up gradually until we reach every facility. Another thing is that quality of care demands change of attitude of the health workers, because doing things better means doing things differently. Because if you do the same thing all over and over and expecting the same result, I don't think it works. So now, to make people change how they do things takes time, because people like to do things the way they are used to doing it. So because of that, achieving the results will not be very immediate. And you don't expect the health workers to clap for you when you come with all your checklists and everything. Don't expect them to clap for you. So you have to really, really, really give some time. And very important, it's not about bringing them to big hotels only. Yeah, you will bring them to big hotels and teach them, but you have to leave the comfort of your office and go to the facilities to really find out how far what you have taught is being practiced. Yeah. And then lastly, it will be very, very important to begin from the early period to think of, okay, yes, we want to start implementing quality improvement. How do we fund it? Especially when funders are leading the process, when there are implementing partners leading the process. It's good to start from the beginning to say, okay, if we do this pilot, how do we go from there? And then for countries like Africans, the African country, I would strongly recommend that from the time the idea is conceived, we start strategize to have a budget line that will drive implementation of QI activities. I think my time is off.
Thank you. Thank you, Dr. Andre. I think maybe you should write some, handover notes for state ministers. I think that would be very helpful. So I'm going to move now to Dr. Okoli, and to think one of the things that Kathleen mentioned in her opening notes was talking about the client experience of care, and it's come up in a number of the presentations. And so what we're going to do is I would love you to just reflect on what does it really take in low resource settings and a country like Nigeria to really put the client front and center in our work. And if you're making some recommendations to another project or another country to work in this area, what are some of your high level, and I'm going to ask you to be quite brief, some of your high level recommendations?
Okay, Chantal, thank you very much. This is quite an important area that is often neglected, people-centered care, respectful maternity care. So one of my recommendations will be to ensure that wherever you're doing this, that first of all, you find out what are the drivers of that disrespectful care and what actually facilitates respectful maternity care, and find out from the stakeholders. So these stakeholders are the women that use the services, the healthcare workers themselves, and other key stakeholders around that environment that we are talking about. Then the next step that I would recommend is that you actually sit everybody down together and actually begin to synthesize from them, because it will come from them, what are those interventions that would actually mitigate this disrespectful care that we all see all over the place. And, there are activities that we know that have gone on, such as ensuring that we are giving the right communication, to the women at the right time, and also, ensuring that they are coming with their companions during delivery or even ANC. But also for the healthcare workers as well, because they also get disrespected by some clients. So you have to also look at packages of caring for carers as well. And I want to just mention here that MCSP, funded by USAID globally, recently actually did a lot of RMC assessment, first of all in Nigeria and other countries. And we're actually in that process of meeting with the stakeholders and getting the interventions, further interventions that we have to mitigate this problem. In fact, yesterday in Ebonyi, we had this stakeholders meeting on RMC to actually see how we move forward. Thank you very much.
Thank you. And my last question, for Madagascar, for Eliane, in an example where we have the quality journey is pretty new, one of the interesting things that came up in your presentation was this very strong commitment to measurement. You spoke about having a core set of 8 indicators, of dashboards, and that sounds very easy to do, but in reality it isn't. And so we'd love to hear some of your thoughts about how you did that. How was it possible? And how did you use that to drive further improvement and motivation? And, out of that, do you have any recommendations for other countries?
Thank you, Chantal. I will start by how we did it. We have to understand that providers are not used to measure quality of care indicators. And it was important from the beginning that we select a common set of indicators to track. Then when we pilot this dashboard in 15 facilities, we're able to really, within a few years, just scale up to the other intervention region by integrating the training on the use of the dashboard, integrating this into the training or MNCH training of the providers. So we are able, the providers were just allowed, were able to understand and link their performances with the dashboard, so they can really see it. But to be able to sustain quality improvement in the facility, we had to train everybody, not just the midwife, not just the head of the facility. So we had to train everybody, and this was done by the third year as we started on-site trainings and on-site supervision. We also had to work closely with the district team and the regional team, making sure that they really conduct this supervision and monitor the facility dashboard. So every supervision visit, every mentoring call was structured around the QI dashboard. So they really were working closely with working on that. So as a recommendation, I would say that it is really important to work with the Ministry of Health to define what are the indicators that really define the quality of, what is impact quality of care. And we have to keep in mind that a dashboard at a facility level will track different indicators for the providers and for the district, but at a national level, national stakeholders need other indicators. So we have to keep that in mind, because there are always expectations that we have to keep, manage. One important thing is, I think from our experience, that it is important also for sustainability to really integrate this within the HMI system. Right now, Madagascar is really transitioning into the DHS2. So we're doing a lot of advocacy right now through the technical working group to make sure that MOH and stakeholders integrate QI indicators and dashboard into the new system.
Thank you, Eliane. So I'm sure now you have lots of questions, and we have a couple of moments. I know I could just keep asking them questions, but I've been told to share. So we are going to have someone who's going to be passing a mic around. And we'd like to ask you 4 things today, and I'm sure you'll be able to do this very easily. 1, please can you ask a question? If you have something to share, please share with us afterwards. Please could you make that question very short so we can have as many questions as possible. Please tell us who you are. We'd love to know. And finally, if you would like to address your question to a particular panelist, let us know. Otherwise, I'm happy to do that for you. So, can we pass the microphone?
Well, thank you very much. And my name is Dr. Amanullah. I'm from Pakistan. I'm representing Vitamin Alliance. I am the chairman of the board in Pakistan. So first of all, my congratulations and compliments to the entire panel and some of the exciting work which has been shared with us. I was just wondering, I mean, a lot of emphasis has been placed on the supply side when we talk about the quality of care. I heard from Dr. Okoli some of the interventions which were done on the demand side, where by engaging communities in terms of assessing the level of respectful maternity care. But if you could share, like, for example, some sort of like the change or impact which we have made by focusing more on the demand side, where quality of care has been promoted as a right of every woman, every child in that community, and how has that impacted quality of care or the results which you have achieved? So an emphasis on that aspect would be really important to hear from you.
Thank you, Dr. Amanullah. Let's take 2 more questions and then we can direct it to the panel. Thank you.
I'm Indira Narayanan. I'm an independent consultant and adjunct professor in the Georgetown University. I'd like to congratulate all the speakers. It was a really wonderful panel. I'd like to ask that it's so good that we're trying to improve quality, and you have shown very good results. What is being set in place as processes, interventions, and indicators to make sure that it is sustainable? In other words, how do we make sure that the stars stay aligned? And the second thing is, as our mortality is dropping, don't you think that we also need now to look into the quality of the survival? Not just the deaths, but also to see how these children, primarily I think it depends more, it affects the children more. How are they developing and how are they growing?
Excellent, thank you. And we've got another question as well from the overflow room, which is really related to quality improvement indicators. Should our quality improvement indicators change as we make progress, and how would you deal with that? So integrating quality improvement indicators into DHIS2 is good, but how do we let them progress over time? So we've got 3 good questions to start. And none of our panelists, none of our audience directed the question, so I'm going to direct the questions. So I think maybe in terms of measurement, if we could start with the DHIS question too. Dr. Onwe and Eliane, maybe you could reflect a little bit about quality of care indicators. And could you reflect a little bit about how you would see them possibly changing over time and how they could, should be linked? You talked, Eliane, about different managers needing different things at different levels. And Dr. Onwe, maybe, thinking about this from a state point of view, if you could just reflect on what's useful for you and how you would like those indicators of progress. You talked about choosing a few indicators at the beginning. Could you just give us your very brief thoughts? Thank you.
Okay. Thank you very much. Yes. When it comes to indicators, because these indicators are tracked at the facility level, but you need to coordinate what is happening at the facilities at the state level, especially if it's a big country like Nigeria. And then we don't want things to end at the state level. We want to also give feedback to the national. Now, if it is very, very important how you select the indicators, because if the indicators are things that are already captured in the national health information management system data tools, it will be easier. If there is already on DHIS, then it is easier for you to track. Otherwise, you may have some indicators that will entail going through individual case notes to know what was done. And that is usually very, very cumbersome. And when you have that, it will be difficult to scale up. So it's best, but at times it is not practicable because some of the things that we're interested in quality of care are not yet captured in the National Health Management Information tools.
Thank you. Eliane, anything to add?
I agree. I just want to add, I think, example we did with the regional hospital, that we have QA teams. So actually, what we did is that we did not develop a common set of indicators for them. They were actually free to choose the indicators that matters for them. So they had to, based on the what really the problem they had, the gaps they identified in the facility, they identified the indicators and they follow them. And we have to be at facility level. I think it's possible because that means that when they have achieved really progress on one indicator, they can just leave it and change to another indicator because they saw that this indicator is a problem. So I think we have to leave the room for the facility to change, but we have to agree that yes, at national level, we need to be able to do on scale. We need a really common set of indicators that we need to monitor at really larger scale.
Thank you, Eliane.
Yeah.
So, Dr. Okoli, would you mind reflecting a little bit about, engaging the community? Your high-level thoughts on, how do we strike this balance about improving the quality of services and engaging communities to use them?
Yeah, like the gentleman actually rightly said, it's not just about the supply side, it's also about the demand and how do you create that. And when they actually come to the facility, that they have the right environment. So I'll just share a couple of things that we've done. So when we talk about these QI teams, particularly at the PHC level, they have membership of the QI team, and the memberships actually are part of the communities are part of that QI team. So you can have a ward development committee chairman or secretary from the community representing the community. You can have a woman leader. You can have a youth leader, a religious leader, part of the community, actually sharing that aspect, representing the women from the community within the facility and in terms of the changes. I must say part of this RMC assessment that I just talked about, done by the Global MCSP project, included the patient satisfaction survey as well. And we're just analyzing the results of that. And one of the things that we have seen the patients have shared compared to the baseline that we did is that they are beginning to see that they have a bit of privacy when they actually go to facility. There are some labor wards that are so small, that you sort of wonder how a bed getting inside there in the first place and then bringing your own family also inside there. People are being allowed companions. It's quite common here, but down in our place, it's not very easy to allow your husband or your family to actually come into the labor ward. So that is being allowed at the moment. And then I would just like to say that there are still challenges. We still have issues around preference. You know, when people come for ANC, for instance, they might just pick somebody that they know to actually go before somebody that has been waiting there, and women complain about that a lot. And then there are also issues around detention, you know, when somebody is not able to pay at the end of giving birth to a baby in a hospital. Unfortunately, some hospitals still detain those women, and those are the sort of things that we want to change in terms of respectful maternity care.
Thank you. And finally, Dr. Sibiti, just some very brief reflections on thinking beyond the day of birth. We've saved a mother and baby. What are some of the things we need to be thinking about, you know, of sustainability in a different context? Just your very brief thoughts before we close.
I'll use 2 examples. One of them is, of course, the issue of early childhood development, but also, most importantly, the aspect of adolescent health. And I think WHO is still working around the standards for quality of care for adolescent health, but we have received at country level a lot of pressure from the adolescent health people and also people working on early childhood development on whether actually we can look beyond the survival issues and then look at the quality of issues, the developmental issues. So we have a small group at country level actually, which is trying to work out some key indicators, looking at the quality of care, because this is definitely going to become very important. Even for newborns, when you resuscitate them, having a system which can actually follow up these babies to know what type of people are surviving is very important. So there's a small group which is trying to identify a few indicators as we wait for WHO guidance to have these indicators incorporated.
Yeah. Thank you.
I wanted also to comment briefly about the issue of DHIS2. I think the most important indicators which can be aligned to quality of care may not be picked through the DHIS2. They need to be qualitative, some of them, and some of them you need to have exit interviews, but also some of them you need to make sure that there's somebody to verify the processes. So we need to use different methods to collect the data.
Thank you. Thank you, Dr. Sibiti. Unfortunately, we're at time for the panel. And thank you to our panelists for sharing your incredible work from all 3 countries. I'm sure that all of you will agree with me that you've demonstrated aspirational goals, practical implementation, and the achievement of measurable improvements. You have definitely kept your eyes on the stars and your feet on the ground. And I'm now going to hand over to Lily Kak, who will be moderating panel 2. Lily is the team lead for newborn health at the Office of Maternal, Child Health and Nutrition for USAID. Lily is passionate about quality of care, and I know that this is going to be a fascinating panel. Thank you for being with us.